And now I'd like to introduce our presenters for today. We have Miss Resa Lee Bell and Adrienne Cotton, and we're just grateful to have them today. So the floor is yours. Take it away.
Okay. All right. Well, good morning, everybody. I'm gonna work on sharing my screen here. So I'm sending a request to share.
Oh,
Okay. So let me try again. Screen two. So hopefully everyone can see my screen.
yes, we can.
Good deal. Yay. I love it when technology works. All right. Um, Good morning. My name is Adrienne Cotton, and I'm the Macintosoa Program Manager. As we go through this presentation, there'll be an opportunity. Risa and I are going to be switching off and presenting through the presentation. So when I'm completed my portion of the presentation, I will open it up for some questions. Of course, you can please submit any questions that you may have in the Q&A to respond to. It will also be helpful for us at the end of this so that we can put together our Q&A questions that you guys ask during this presentation, and that way this presentation and the Q&A can be posted where it's available and accessible to folks for you to get access to review if you want to do that, or share with others who weren't able to attend today. So and then, of course, there's going to be some other questions. So if folks can, like, I don't know, thumbs up or clap your hands, put a heart up, that kind of thing with some of the questions that we're going to ask, that's great as well. And so I'll go ahead and get started. So I want to thank all of you for having us today. We are very excited to share with you our caregiving programs. Family Caregiver Support Program has actually been around for several decades, and now we have the Medicaid Alternative Care and Tailored Supports for Older Adults, which has actually been approved to continue for another 5 years. So that is very exciting news. We've been through many changes and updates have happened since our last presentation we did with this group, which I believe was in 2022. We did a brief presentation. In 2019, we did a big presentation like this. Lots have happened since then. But before we begin, we'd like to introduce ourselves. Again, my name is Adrienne Cotton. I am the Macintosoa Program Manager. I started with Macintosoa Program as an intake supervisor for Region 3 when we rolled it out in 2017. I'm really passionate about these programs because of how these programs have been able to help so many people that would otherwise go without any supports at all because they don't qualify for long-term services and supports. Having been an APS investigator with Adult Protective Services, there were a lot of cases that these programs could have benefited many of clients that I worked with. I would also like to share that these programs have been able to be utilized for me on a personal level, having been a backup caregiver for my dad who cared for my mom and caregiving for my mother-in-law who suffered from Alzheimer's disease. These programs have brought supportive case manager, resources, information, education, support group options, as well as respite services, and so much more. And that's enough about me. So before we're moving on with our presentation, I would like to introduce Resa Lee Bell, who is our presenter today. So Resa.
Thank you, Adrienne. Hi, everybody. I'm Resa Lee Bell. I'm the 1115 Waiver Program Manager with ALTSA headquarters in the Medicaid unit. I pretty much do everything policy related, like monitoring, development. I work in conjunction with Adrienne to do the implementation of policies and practices with our area agencies on aging and staff that work on the MAC and TSOA programs. I actually started in a similar path as Adrienne. I was laughing when you said that because I started with MAC and TSOA as an HCS intake supervisor as well, and then have been in this current role for about 2 years. And I came from the title side of things, so it's different. But just the pure value of our unpaid family caregivers and learning so much from the Family Caregiver Support Program and Adrienne with her history and backstory of the caregiver programs that we have available in Washington. It's just been an amazing opportunity, and I still learn every single day. And so I'm excited to be here today as well to share our great programs with you. We are just a subset of the LTSS whole benefits package offered through ALTSA. But I think this is really important work that's being done in our state. Our unpaid caregivers are invaluable. Just Adrienne will talk about it in a little couple slides. So we're super excited to be here to present for you guys. So thank you.
All right. Thank you, Resa. So yes, in my current role, I started in 2018, just as we kind of just started rolling this out at headquarters. And I actually work with all of our area agency on aging and monitor their contracts for the MAC and TSOA programs. So MAC and TSOA was implemented in September of 2017. As Resa also indicated, it's part of an 1115 waiver, but that I believe was divided into 5 initiatives, maybe 6. It's kind of kept growing as things have gone along. MAC and TSOA is under Initiative 2, and it is the only program that is managed under Home and Community Services through 2 entities, State Unit on Aging, which is the unit I'm in, and the Medicaid unit, which is what Resa is in. So the funding is 100% Medicaid funds. And in the first 5 years, actually ended up being 6 years due to COVID, we were able to show a decrease in the use of institutional placement of clients when supporting clients in these programs, in particular unpaid caregivers. Because of our success in the first 5 to 6 years, we were able to get approved for a second 5 years and receive 100% funding from Medicaid again, because there was kind of some question whether that was going to happen or not. So what are we going to be talking about today? We're going to actually talk about how to identify unpaid caregivers. What is MAC and TSOA, Medicaid Alternative Care, and TSOA, Tailored Supports for Older Adults? What is Family Caregiver Support Program? How does that come into play? Who do these programs benefit? How to make a referral for these programs? How these programs can assist with discharge planning? And then also the unpaid caregiver outreach that we've been doing. So this is a, who here today, just by like a show of hand, you can do it, whatever symbol you want to use today, has experienced being a caregiver for an adult in the past? Just by show of hearts, thumbs up. Lots of thumbs up and hearts. Yes. Who is currently a caregiver right now? Yeah. Lots of people. Not surprising. We have lots of unpaid caregivers in our state. And then who expects to need a caregiver in the future, maybe? Right? We don't want to admit that or think that, so far in the future, but we're not getting any younger, unfortunately. Right? So if you don't fit into any of these categories now, the likelihood that you will increase as you age or your relatives and friends age over time. And we know that it is a common human trait to conveniently ignore the fact that our loved ones are aging until it becomes an impossible situation to ignore. And that's one reason many people don't understand that they are a caregiver, especially in the early stages of the caregiving journey. One of the biggest challenges we have had was helping to identify unpaid family caregivers, because most people are providing assistance, whether it's just a little or a lot, is considered actually giving care to others, which is our human nature to give to others. Not to be confused with the paid provider caregivers. You may just be taking meals to your neighbor, taking your dad to medical appointments, or you're caring about someone and helping them out. You may call it helping your dad with his medication. We call it caregiving. And caregivers don't have to be family, even though you may hear the phrase unpaid family caregivers, which actually comes from family caregiver support. This can be anyone a care receiver determines is family and want to care for another person. Another reason caregivers are hard to find is that caregivers usually identify only as their familial role. You will hear, I promised in my wedding vows to take care of my husband or spouse or wife or significant other is what I'm going, and it's what I'm going to do. Or I'm just her son or daughter helping out with a few things. So at some point in all of our lives, having a caregiver journey to share, or we'll begin our caregiving journey soon because we care about others. Finally, most family caregivers will eventually call the Area Agency on Aging for assistance. And Resa will kind of talk a little bit more about that when she talks about how to make those referrals. And they've usually heard about the Area Agency on Aging, or what we call the AAA, not to be confused with the auto AAA program. That'll be a AAA. So I myself have had many conversations in grocery stores and doctor's offices while waiting in appointments. And have noticed an uptick in calls from friends and acquaintances as their parents fall or have other medical events. Most people are woefully unprepared to be a caregiver or to watch their loved ones change as their care needs increase. So we're going to hear more about some of these great programs that the AAAs offer. So before we begin with that, I have a little video to share called The Day in the Life of a Caregiver. Hopefully this works and you guys can hear it.
Everyone deserves access to healthy food, but not everyone can get to a food bank.
Where's it shine? Okay. Okay.
He said, she said,
Flip.
Okay, it's a nice little intro to the many. Yeah, I'm sorry, I get a little emotional when I watch that. Um, but what all of our caregivers do in our state. So, what is an unpaid caregiver? Anyone can be an unpaid caregiver in any capacity, in any phase. We're caregivers of our children, and then caregivers of ourselves and each other, and then family members, friends, and neighbors. So some questions before is that what does caregiving mean to you or the patients that you serve? So be thinking about that. What does a caregiver look like to you when they come in, when you see them? And what does that look like for your patients? Do you see friends and relatives and patients who are stressed and caring for a friend, relative, a neighbor? Do you know someone who is a caregiver? And are you a caregiver? And we did ask that question earlier. We have over 860,000 unpaid caregivers in the state of Washington alone, according to the AARP. That is a lot of people. These programs we're going to talk about today can help and provide supports and services. And even with family caregiver support and even the current enrollment we've had with Macintosh SOA, we've just barely scratched the surface. Later in the presentation, we're going to talk about how you can refer clients and how these programs can help support the work that you do every day. So how do we identify an unpaid caregiver? Unpaid caregivers may provide up to 80% of the care patients may receive. As I mentioned earlier, many people don't identify as being that caregiver. They're just someone who's helping out others, such as a spouse, a friend, a son, daughter, sibling, neighbor. It's someone like you or you that's here today. Maybe it's one of the neighbors helping to mow someone else's lawn, a patient that's coming in and they're not taking their medication, who shares with you they've been caring for an ailing parent and haven't been able to take care of themselves. They forget taking their medications because they're constantly putting out fires with the person they're caring for. Maybe it's a patient who has a sibling or adult child that always brings them to medical appointments or to the ED. And they don't label themselves as a caregiver. They may have another definition of that or an idea of what it might look like. They're helping their parents because they helped raise them and they're returning the favor. Helping others, especially over a long period of time, can be very exhausting and very stressful. One minute things are going okay, and the next they aren't. The person your patients are trying to help may be angry all the time and yelling because they don't want to depend on others to care for them. They're sick and in pain all of the time. We refer to these caring individuals as unpaid caregivers, and they do what they do because they care and want to help, and they may not identify as being an unpaid caregiver. That being said, many may not be aware that there is help out there for them, and that's why we are sharing these programs with you today. Some technical issues going on here. There we go. So unpaid caregivers not only help with medical tasks, but also with daily living tasks such as bathing, exercising, running errands, as you saw in the video. No unpaid caregiver is identical to another. They all have their own journey that they experience, and they may need support and assistance. If we look for clues or ask certain questions, we may be able to help identify those unpaid caregivers so we can get them going in the right direction. Unpaid caregivers shoulder a huge burden. Again, there's 860,000 unpaid caregivers in our state alone. Washington was one of the first states to see family caregivers as care recipients. In the 1980s, our legislators realized that family caregivers could be caregivers longer with better health if they were given respite services. They also believe that family caregivers keep their care receivers out of more costly care alternatives like nursing facilities. In 2013, ALTSA, the Aging Long-Term Services Administration, which is the umbrella agency that Resa and I work for, did a data analysis and found that was true. Unpaid family caregivers are the backbone of our long-term care system, and we know that caring for a family member or friend can be rewarding, but often does have many negative impacts on unpaid caregivers, such as long loss of earning potential, decreased savings for retirement and Social Security, impacts on the ability to provide for their own children's needs. We have a lot of people who are what's called in the sandwich generation, where they're caring for young children and they're caring for older adults as well. Increased healthcare costs due to caregiver stress and burden, long-term effects like chronic diseases, We also know that there's a high economic value for our state and federal government when family caregivers are providing the care. The care unpaid family caregivers provide in Washington is estimated at $10.8 billion a year. Huge, huge. Of that, if 1/5 of our current unpaid family caregivers stop providing care, it would actually double the cost of long-term services and supports in our state alone. That's huge. So next, one of the looming issues that will have long-range effects is the caregiver support ratio is actually declining. As people in the United States have less children, in 2010, each care receiver had an average of 7 people who could care for them. And in just 7 years, that care receiver or caregiver ratio has fallen to 4 caregivers to each care receiver. By 2050, that ratio will be 3 caregivers for each care receiver as the large baby boom generation ages. To exacerbate these falling ratios, Washington's direct care workforce, the paid care providers who we call on for respite services, was always sparse before the pandemic. The lack of direct care workers is a widespread issue affecting the United States, Canada, and most of European nations. These 2 issues make the need to support family caregivers and paid care providers critical for our future. We need to become more innovative in the financing and delivery of LTSS and unpaid family support services. And you can get more information. There's a link in this PowerPoint that for the www.aarp.org home family caregiving info, and it's info 082013, the aging of the baby boom and the growing care gap with ARP. So you could probably plug that in online. So now we're going to talk about the Family Caregiver Support Program and their efforts to help caregivers. And we were able to prove how it benefited supporting unpaid caregivers. Since 2009, Washington has been gathering data about our state's caregivers using an evidence-based assessment process. Many other states are just now exploring evidence-based assessments. We use what's called T-Care is our assessment. The Family Caregiver Support Program has been in place for several years, and through surveys and data analysis was completed, showed that over a 6-month period, 84% of caregivers who received ongoing support showed significant improvements in stress levels because they become more comfortable in their caregiving role. It decreases their stress on the relationships, and additional for spousal caregivers also show a decrease in intent to place their loved one and decrease in symptoms of depression because the caregiver is able to maintain objectivity, decrease in burnout. Because of the data we were able to obtain, we were able to present this information to the Centers for Medicaid and Medicare, which led to the implementation of the MTP 1115 waiver, now we call Medicaid Alternative Care and TSOA Tailored Supports for Older Adults, TSOA for Older Adults, tongue twister, MAC and TSOA. And of course, again, this is only one of the many initiatives under that waiver. Through this program, we've been able to provide supports for over 4,800 caregivers in our state with these programs alone. Surveys also showed that family caregivers who access support early on not only had better health themselves, but it also delayed the use of their loved one using traditional long-term services and supports. So now I'll be sharing another video on why utilizing these programs is important.
Hey, Adrienne, I checked the chat in the last video.
Don't open your car door while submerged underwater. A fatal construction flaw in all recent automobiles makes it virtually impossible to escape the car after crashing into water.
Okay, go ahead.
Oh, I was just going to say, it got choppy and then we lost audio. It's like we could hear a little bit of music, but we couldn't hear what words we're saying in the last video. So that sounded really clear just now. So maybe we'll be okay, but I just want to give you a heads up.
Yeah, there were no words in the last video. It's just music.
Oh, well, we heard chops of it.
Yeah, so it was just like it was, yeah, so there were no words. It was everything was red on the screen for the last one. So hopefully this one will go better. Crossing my fingers. Thank you.
So family caregivers can really be anybody. It can be a parent or a child or a sibling, a friend, a neighbor, and that's how we're defining family caregivers. So for us, a family caregiver is whoever the patient says the family is. There is no typical caring experience or caregiver. Everybody is different. You have parents who care for ill children. You have young carers caring for their parents, siblings, or grandparents. You have someone caring for an ill spouse or for an aging parent. And you have friends and neighbors as well that care for their friends and neighbors. 75% of family caregivers work, which is a lot, but many of them don't work. And you also have a lot of caregivers who are in the sandwich generation. So they're caring for an aging parent and they have children at home at the same time. There are so many issues that caregivers face. Some of them are emotional, and they can range from isolation and loneliness, and there's also a lot of guilt that accompanies caregiving. Some of them are financial. There's a lot of pressures on caregivers. They may lose their jobs because of their caregiving responsibilities or have to reduce their hours. And just the challenges of working flexibly that are needed when you're a caregiver come up very often. And then there's the everyday considerations of how do you navigate the system? Most caregivers have no idea how to find services. And then there's the challenges of how do they get enough respite care for themselves so they can take a break. And some caregivers can't get any care at all for their loved ones, unfortunately, in Ontario today. And that's why caregivers are starting to burn out. And we're hearing that the rate of burnout of caregivers has doubled in the last 4 years. And it's now at 33% of caregivers. There's real value in listening to family caregivers because they're often the individuals who see the patient experience from the very beginning of an interaction to the end. And sometimes the patient isn't always aware of all of those interactions. So they have real wisdom in terms of what the system is actually able to provide or not provide. And they also are usually the most knowledgeable person about the patient themselves. And so we really think the system could learn a lot by bringing families into the conversation and listening to what they have to say.
It wasn't nice.
Okay, so a lot of areas throughout like the United States and Canada are working on trying to put these programs together because we're seeing that it really does make a difference within our communities. So let's talk more about the Macintosoa program. Once we were able to convince Medicaid, go ahead.
That was my slide.
No, this is mine.
Oh, I had it as me. Okay, you go.
Yep. I got the next two, and then I'll have you get the next one. So we were able to convince Medicaid that supporting unpaid caregivers would save money in the long run, especially with the increase of aging population described earlier. So we mirrored Macintosoa after the Family Caregiver Support Program under the 1115 Waiver Authority. And this program was innovative in many ways. It is the first time Medicaid has 100% funded a program that supports unpaid family caregivers. We also implemented a new process to help speed up the process of enrollment through presumptive eligibility, which Resa is going to talk about a little bit more, and which has led to the implementation of this process in other LTSS programs such as COPES and Community First Choice. So the goals of Macintosoa is to have the right service at the right time, to be able to more easily and readily access services, to expand person-centered choices, to support unpaid family caregivers or unpaid caregivers and individuals in preventing them from having to seek out institutionalization sooner, and then also delay or avoid the need for intensive Medicaid funded long-term services and supports. Now I'm going to turn it over to you, Resa, to talk more about who it benefits and how to make those referrals and so on.
Perfect. Thank you. Um, so the services under MAC are intended to wrap around the informal caregiver. So they are supported and able to continue providing quality care to our care receivers. Also, we do have an individual TSOA tract, and that's for individuals who they don't have an unpaid family caregiver, but are wishing to seek some kind of MTP services. Often to SOA, you'll hear it referred to as like expanded Medicaid. And that's typically just due to the higher resource and income limits, which we'll talk about in a little bit. But one thing that we always try to make sure people are aware of is that our TSOA benefits package doesn't come with that, like the Apple Health Medicaid that most of our LTSS services do come with. And we can go to the next one. So the who is eligible, I think this is a great comparison chart of the eligibility for our MAC and TSOA programs, as well as we added the FCSP on here. So then it helps just when you're trying to determine what kind of referral you're going to make. So for eligibility for both the MAC and TSOA programs, it's going to be based on your care receiver. And so for MAC, you'll need the clients will need to be 55 and older. They need to be enrolled in a CN, which is a categorically needy, or ABP, alternative benefits plan coverage group. So that's their Apple Health Medicaid. They need to meet nursing facility level of care, and they need to have identifiable, they need to be a dyad. So that's your unpaid family caregiver and your care receiver combination. For TSOA, clients need to be 55 and older again, have a monthly income less than $3,772, with resources less than $71,394 for a single individual, or if they're married, it needs to be less than $139,695. They also need to meet NIFLOC. They can be an individual or a dyad in this situation. And they would need to submit the 18005, that's our long-term care application for TSOA. An important note on this is those amounts are scheduled to change on January 1st, 2025. So they're going to increase a little bit, just in case you have somebody on the cusp and you're looking at doing a referral. For FCSP, the care receiver is age 18 or older with a functional disability, or age 60 and over. There's no financial eligibility criteria, but there may be some requirement to pay all or most of the cost of the respite services, depending on the person's monthly income. And there's no immigration status requirement, where the MAC and TSOA ones do. And we can go to the next one. So the next one is giving just a couple examples of like who is eligible. So a dyad, which may be either MAC or TSOA or family caregiver support, may be like a care receiver which has dementia, diabetes, and behaviors that cause the caregiver stress. That might be a good referral to those programs. An example of TSOA without an unpaid caregiver may be an individual that lives alone, doesn't have help from anybody else. The care receiver needs help with medication management, maybe is afraid to bathe without assistance, and they might be interested in that TSOA individual track. So here's some new terminology. So presumptive eligibility. So in both the MAC and TSOA programs, we have what's called presumptive eligibility. And presumptive eligibility, some say it's like similar to like fast track, which is it allows us to gather like preliminary information based on the care receiver self-attestation to decide that the care receiver appears to meet both functional and financial eligibility criteria. And if so, we can go ahead and start services before we go through that full functional and financial determination. So it really helps, like when Adrienne was talking about getting services for those unpaid family caregivers, like timely and expedited, that presumptive eligibility plays a big part because we're able to put interventions in quicker. Um, so as you can see, there's 3 steps for our MAC programs. So step 1 is just a one-time benefit for $250. And that can be accessed just immediately after doing a presumptive eligibility with staff. Then there is step 2, which is $500 per year. And that can be accessed after PE eligibility and the Get Care or T-Care screenings completed. And then step 3 is $818 per month, and it's not to exceed $4,908 in a 6-month period. And that can be assessed after the PE, Get Care, T-Care screening, and then the assessment. Care receivers and caregivers may choose services up to the amount allowed for that step benefit level. Another thing important to note is that those amounts for like that the step level, step 3, that changes when the home care agency rate changes. So we typically see that happen in July and January each year. And the rate's been going up. And so we've been seeing that sort of tick up a little bit for the spending budget. So then what services is like the next question. It's like, well, what kind of services can you get under this program? So we offer our services under really 5 primary benefits categories. We have personal assistance services, and that's for our TSOA individuals. So that's with TSOA without a caregiver. And those help individuals complete like everyday activities to just remain in their home. And then we have our caregiver assistance services, and that's for our MAC and TSOA dyads. So these are services that take the place of those typically performed by the unpaid caregiver in support of the unmet need of the care receiver. So that could be assistance with activities of daily living. It could be assistance with instrumental activities of daily living. We have the training and education component, which can help the caregivers gain skills and knowledge to care for the traditional client and help them maintain independent living for as long as possible. We offer specialized medical equipment and supplies, and that includes items that may be also known as like durable medical equipment and specialized equipment and supplies. Sometimes SES or DME, you'll hear it called. And then we also have health maintenance and therapy supports. And so that's really to help caregivers remain a caregiver or the care receivers to remain at their home in the community. We put an extra little add-on in there for when we got that waiver renewal that Adrienne was talking about earlier called MTP 2.0. We added additional services to the MAC and TSOA benefits package, and that those were some high requested items. So we requested those in our waiver. So we added specialized deep cleaning. We added community choice guide services. So that's excluding the purchasing of goods and services and issuing payments, as well as no emergency rental assistance. But that having that community choice guide being able to help connect some our care receivers with resources in the community and stuff, we are finding that very beneficial. And we also added pest eradication. We did also expand the nurse delegation to go in conjunction with respite care. It was just for personal care before. So now it's we have nurse delegation under all of our programs. So both MAC TSOA dyads and TSOA individuals. So an important note on here is that although the MAC and TSOA programs, they do offer short-term respite in facilities, we don't offer any ongoing residential component. So typically like say somebody needs a caregiver just needs to take a break from their caregiver responsibilities, and they're like, oh, an adult family home can take them for a day or 2 days to give them that little bit of respite. But we wouldn't do anything like you see on traditional LTSS where somebody's placed ongoingly. And so I think this is a great visual of the various services that are offered through the MAC and TSOA's benefits package. This is not an all-inclusive list. This is just some ideas to see what kind of services are offered. And it's like with all of our programs that are Medicaid funded, we always have to exhaust all other insurances and all other resources first before we're using Medicaid funding. But this is just a great example of some of the services that you could see some of our care receivers and caregivers taking advantage of on our program. So, also part of our waiver renew, well, our initial waiver and our renewals, we did request for exclusion of estate recovery and participation or client responsibility. So both of these do not apply for participants under MAC and TSOA programs. Though our benefits package is more limited compared to traditional LTSS programs, for someone needing just a little bit of extra help or the caregiver support, these programs are great to help meet those needs. And so intakes, like where do they happen, right? So we really try to follow that no wrong door policy with our program. And so intakes can occur either at the local area agency on aging or the home and community services office. There are designated staff with HCS intake staff in each region that are handling MTP cases. So typically this would entail the worker doing the presumptive eligibilities that we talked about earlier, and or they're going to be confirming presumptive eligibilities if they get if the person goes in the AAA front door. And then the staff also do what's called a warm handoff. We call it a WHO, where we want to make sure that because we're transitioning between offices that the cases successfully make it, the referrals make it over, right? So we're trying to really collaborate with our AAA partners to make sure that cases transfer over successfully and we can expedite and get those services in place. The AAA staff, they're responsible for completing the assessments, the care plans, the service authorizations, and I know I said it earlier, but all their work is done in a system called Get Care, which I know most people are used to hearing care. So this is a secondary system that our AAA workers will work our MAC and TSOA cases out of. And it's also just, I always think that it's very interesting because some of our AAAs, their staff wears multiple hats. So you might see some staff they might be MAC TSOA staff, they might also be community living connection staff doing a little INA, and then they might be FCSB staff. So they're very, their expertise is across the caregiver programs. So it's just amazing the resources that some of these AAA case managers can be. And so if you have a person that you're like, oh man, they would really benefit from these services, we're going to go over making the referral and then also the application process. And so like we talked about, there's no wrong door. Referrals can be made through the local community living connections or the AAA office. And we have a link there. And I think Anthony will get this so you guys can have access to that. And then also it can be done through the local home and community services office. I did put a little snippet of the intake and referral form. So that varies by location and region. Most of the time your local, if it goes through HCS intake, they'll be talking to you how they want you to send their referrals to them. But that's an option too that intakes will use to start the TSOA, to start that initial professional referral, so then they can outreach to the care receiver or the caregivers. Both the information assistance staff through the local community living connection staff and the HCS staff, they're going to be the ones that are going to be helping have like that person-centered conversation and helping the care receivers or the caregivers make an informed decision on what kind of services might best meet their needs.
And Resa, I do want to add too that because a lot of these folks are medical professionals, we do have a special area. It's called the Refer a Patient portal in the CLC set here. In fact, just real quick before you move on, I'll just kind of do a quick show for that.
Oh, that'd be awesome. Yeah, thank you, Adrienne.
So let me see if I can open this up so people can have a visual. So when you click that link that's in the message here, this is what's going to come up. And for those of you who are working with clients who may have an unpaid caregiver or need some of that support, you click that little box there. I'm going to go back just really quick in case you missed it. So it says people helping family and friends, unpaid caregiving. Of course, there's a huge amount of other resources and stuff available in here as well. So you click that, and then up here where it says connect, you can click connect. And then here, and so you can pick what area you are from, which county, to specify that. And then you can click refer a patient. And you put in your provider information, what clinic or hospital, any contact information there. And then it actually asks quite a few more detailed questions, questions about the patient, if there's an alternate contact, who might be able to be contacted. And then what are some of the initial concerns with regards to the patient, to help elaborate on, what are the big concerns and issues that are going on? Do they suffer from chronic pain? Are they homebound? Are they already a Medicaid client? Because that can be really helpful. And any additional concerns. And then, of course, we have a disclaimer here on terms of that, did you obtain permission to release the above information to the local area agency on aging and information assistance program, which helps with that HIPAA. So that can be clicked, and then you can get that submitted, and that'll go to your local area agency referral information and assistance site for the folks at the AAA to pick up. And it's kind of nice too, because it also gives the option, especially if you have workers who work late at night, they work swing shift, graveyard, calling the AAA, they're just going to get a voicemail. They can just provide all the information that's needed, and even indicate, if they want to get a call back or not, in regards to that particular referral. So the AAA knows they can move forward with that, just like reaching out to the client, so on and so forth. So it can kind of expedite those referrals when they are submitted by a medical professional. Just wanted to share that. So thanks, Resa.
Oh, no, thank you, Adrienne. That was great. I'm sure everybody on the call appreciated that. Walkthroughs are the best.
Yes.
Totally. So applying for services, this slide sort of applies for traditional long-term care services and supports. We can go to the next slide. And to SOA. But typically, referrals are made through Washington Connection or the Washington Health Plan Finder websites. If applying for TSOA, typically that's done through the Washington Connection website or completion of the 18005. That's our classic long-term care Medicaid application. I'm sure most people are aware of that, but it's available at your local AAA offices. It's at the HCS offices. I know, like, encouragement is to do all the stuff online because that does help expedite things versus hard copies. But yeah, so that's those are the resources to help somebody if you're assisting them to apply. And for applying for FCSP, you would want to contact the local AAA office in that scenario. And so with that, I am going to turn it back to you, Adrienne. You're muted.
So before we move on, there were some questions in the Q&A. So one, how would someone access PPE like gloves and masks?
Sorry, I was like, I had to go I was going to answer and then I was like, oh no, I got to go to the unmute. So for our MAC clients, typically gloves would be purchased through their Apple Medicaid health benefit. And then for our TSOA clients, we would purchase that through our specialized SES providers, and that would be purchased out of that person's step benefit level.
Is there a standard turnaround time once a referral is submitted?
I wish there was. It's going to vary based on location and region. Um, and so we always strive. We definitely want to try to get services in place as fast as we can. One of our recent strategic initiatives, I think a few years ago, was like our goal is trying to get it within 45 days. But that was for traditional long-term care. For Mac and Tasoa, I think the AAAs, I don't know, Adrienne, if you have any statistics, but I do think the AAAs are, they work, I feel like they work those really fast. And once it goes through intake, like when I'm reviewing cases and stuff or helping out, I feel like within days, weeks, they're trying to make contact and get services in place. Do you have any statistics, Adrienne?
I don't have any statistics, but I do know as part of our WHO protocol, they need to be at least touched within 48 to 72 hours to reach back out. Obviously, the more automated things are done, so like using the referral portal, submitting the applications online, those definitely get a lot quicker submitted. If you go direct to your AAAs, they usually will get things rolling pretty quickly. And that's really nice with the presumptive eligibility component because you don't have to wait for the financial approval for the services to start. As soon as that person meets nursing facility level of care, and they are considered presumptive eligible through the attestation, then they can as soon as they can get a provider lined up and get services figured out that everybody agrees to, they can start getting those things set up within 30 days of the application or their referral being submitted. So but yeah, so
That's so we got a comment that says, I've been referring clients to this program and someone has called them to set up assessments within a few days. It's never been over a week that they heard from someone. Yeah. I feel like our MAC-TOSOA program and FCSP actions taken quicker than a lot of times with the backlog that we sometimes see with our traditional LTSS programs.
Yeah, and the one of the challenges too is that if someone, at the hospitals and stuff, they'll submit an application and then they check everything. So when they check everything, that it goes through the process of going through the financial review eligibility for everything, which means, and the eligibility review for MAC and TSOA is much shorter and less documents needed than it is for your CFC, your COPES, and community first choice programs. So that can make a big difference in terms of timeline. If it just checked TSOA, then that can get expedited that way. But we often recommend that if you have someone and you're needing assistance with working through discharge planning, is reaching out when it comes, if it looks like these are folks that would be better suited to do the MAC or TSOA program. It's not to be a stopgap for them, just to get them something until they get set up on long-term care, because there's a lot of work that goes into getting these people set up on these services. But if it's a really good fit, you could just go directly to reaching out to the AAA, like going through that portal I showed you, and that gets it right to the AAA. They get right in there. They reach out to those folks and they can get things rolling and figured out. And it doesn't always necessarily have to be, saying, oh, well, it's TSOA or that. You could just say, I think I'll just refer this person over to the AAA. They'll have that conversation with them to see, okay, what's the best fit for them? Should they go long-term care route? Should they go? And they can help assist with the application process and different things like that. The AAAs are amazing people.
Agree.
Mm-hmm. So, okay. No other questions that I can see. Okay. So, one of the challenges that we had when we first started rolling this out is, again, I've talked a lot about identifying caregivers. And so these were actually some of the ways. So another milestone with this particular program is that it was the first time Medicaid actually funded a program to pay for outreach. And so these were the many things that we did to promote these programs across our state, whether it was billboards, buses, movie theaters, anywhere we could put this up and saying, look, if you're doing these things, we have support for you. We have help for you. We've actually just a total, I think we've actually enrolled over 16,000 care receivers in that program, and about 30% of that is caregivers. So add that 4,800 or 5,000, so 21,000 people we've been able to help through these programs since the rollout in 2017, which is absolutely amazing. But we still have another 840,000 people to help. We got a lot of work to do. So some other outreach materials, and we do have these materials available. If you are interested in being able to obtain this kind of materials for your places of work, we can get these to you. We have rack cards, which are just little rack cards to promote it. We have posters. We actually put a lot of posters at the community services offices, and things can be posted up around different places, put on elevators. And then we also have our brochure that can be handed out that talks more about these particular programs as well. And different AAAs will have different things. These are placemats that we actually put together. Great opportunity that, hospital cafeterias, these can be put on the trays to promote the program and show what's available. And it kind of just asks some random questions. And we've got like 4 different versions of it. And on one side, we have like questions. And on the back side, we have like answers and more information about how to qualify and where to contact and who to reach out to. And of course, many of the AAAs do their own outreach as well in your local areas. So if you're hearing some things about those outreaches, please, attend or, go by and check it out. And they have a lot of their own outreach materials as well that they utilize. So I have another video, but I'm seeing that there's a lot of people. So yes, thank you. I will. So if you are interested in receiving like brochures and information, please send me an email and let me know with your contact information, what you're interested in, and then I can see what I can do to get things mailed out to you. So there are some other questions I see. Are spouses eligible to become paid caregivers for their spouses, or mothers be paid caregivers for their children? So 2 different groups. One is that no, Washington State does not allow spouses to be paid caregivers or be individual providers. That is something that we're revisiting as a state, but we're still in the talking stages in terms of, what would that look like? A lot of that had come down to is there was a big giant lawsuit that occurred when a spouse was being a paid provider, and unfortunately it resulted in a very devastating situation of the person they were caring for. It was a very abusive situation and resulted in a major lawsuit for the state. So they decided to no longer allow spouses to be a paid provider. But it was a long time ago, and we are revisiting that, but we're not there yet. However, anyone else can be an individual provider. So that's the exciting thing, is we just implemented in June for people in our programs to be a paid individual provider, especially with the caregiver shortages that we've been experiencing in our state. Now, mothers, I'm not sure. Is that from the DDA world? Mothers can be a paid caregiver for their children?
Yeah, DDA has different criteria, but for our program, yes. It could happen. Like our criteria is older adults, right? That we're seeing with Mac and Tessoa. But yes, if there was a parent that was caring for somebody that met our criteria, they would be able to get signed up through CDWA to be the individual provider for our programs. Yeah.
Okay.
But we should have mentioned the individual provider thing, because I think that was probably when you guys had your previous presentations, it was only home care agencies. That's the only choices that people had for their home care. And so now with the expansion of being able to use individual providers, that we feel that that's going to really open up the doors for people who really want a loved one to be providing their assistance to them for their paid assistance.
Yeah. Yeah. So that is an option. And I'm putting my email in the chat for those who are interested in having those, like having outreach materials and things like that. Let me see.
Are you reading the
I'm reading the chat.
Okay, I got a couple on the questions, the Q&A. Do you want me to go to those?
Yes.
Okay.
Can do that, and then we can bounce to because there was a couple more. Can we refer caregivers to home care agencies? Yes, you can. It is up to those home care agencies to decide whether or not they would like to hire that person. That caregiver does have to go through their hiring process in order to be considered and be an employee of that home care agency. If you have an individual provider or a caregiver and they're interested in maybe being an individual provider, you could also go the route of having them go over and register with Karina, and Karina will be able to get them on the list of being an individual provider through that. Yeah. So back to the question about spouses. That is in the works, but it was passed through legislation. We're waiting for us to do our part with the pilot program write-up. So that is correct. So we are working on that. Let me see. Just want to make sure I cover all that, and then I'll jump to the Q&A. So thank you for that. Okay. So we've got some people that went and talked to the legislature. We've got some parent providers. Yes, okay. Family members can provide, including siblings. Expansion on that. And then Karina.org will pay them. Okay. Yeah, so I'm not sure how all that works as far as Karina goes and payment. I know if they do go the route of working with one of our clients, they need to go through CDWA or Consumer Direct Employer, even though they're already, just to get linked up with a DSHS client, because there's a matching that has to happen through the CDE system when working with DSHS clients. As far as just being a paid caregiver through Karina for other things, but I believe that with Karina as well, because we just set something up, they also need to verify that the caregiver is a DSHS eligible client as well for Karina. So there's kind of a couple of different things that to go through with that when it comes to providers through that. Okay. Okay, so there's that. The slide where you showed the step 1, step 2, step 3, can you clarify what that means? Okay, so what the step 1, step 2, step 3 means is when a person comes through the door and they complete the presumptive eligibility and the nursing facility level of care assessment, at that point in time, they qualify for $250 one time a lifetime in services right through the door. If they want to go to the next step, they need to complete a screening. If they complete that screening, then they can receive step 2 services, which is $500 one time a year. That's it. That's all they get. Now, if they went through the process of getting the $250 at step 1 and they're like, oh, I want to complete the screening, and they complete the screening, then then they get some bump to that $500 once a year. They only will get an additional $250 for that. If they want to get step 3 services, which is the $844 a month, is what it averages out to, that will get them, they have to complete the assessment process. And that is for both care. So if it's a dyad, it's the care receiver that has to complete the PE and NIFLOC. If it's a individual, or if it's a dyad, it's the caregiver or care receiver that completes the PE and NIFLOC. It's the caregiver who needs to complete the screening and the assessment, and the care plan is done with the caregiver. If it's an individual, everything's done with the care receiver. So yes, so it's $250 one time for a lifetime for step 1, $500 a year. And then the next step is $844 a month. And that amount changes with the home care agency rate changes every year, or it's every 6 months that changes. So that rate can actually increase or decrease depending on how things go with that particular estimate. So the money does not compensate the unpaid caregiver. That is correct. It provides respite services, supplies, incontinence supplies, gloves. It provides home modifications, wheelchair ramps, counseling, support groups. It provides all of these things. So when you're working with patients or clients in regards to talking about this program, to make it clear that they're not going to get a deposit of $844 into their account. That's not how it works. What's going to happen is they get approved for this program. They have a conversation about what services they're interested in being provided. And then we do authorizations through our Get Care system that goes over to our Provider One system that lets the provider know that there's someone interested in receiving services. And then, all that coordination happens. And then Provider One is directly paying the provider. There's no money that goes to the client or the caregivers at all in that instance. The only time that any money would be given to a caregiver is if they apply to be an individual provider through the consumer direct employer, in which case they'll receive payment directly from CDE to the individual provider. That's applied through CDE. So you have family utilizing TSOA. It was a quick turnaround, which is good. Yes, it did. Unfortunately, it does take some time, especially in the more rural areas, is a challenge to find those caregivers. So to utilize the massage therapy and acupuncture, I don't believe we provide chiropractic services. So the challenge with, we have these services that we can provide. The question is whether the AAA can find a provider who's willing to contract with them in order to provide that service. I know some of AAAs in some areas are working really hard and have been able to obtain a massage therapist willing to contract and utilize the Provider One system, because that's a requirement for Medicaid. I don't know of any AAAs who've been able to obtain an acupuncturist. There might have been one, but I know that they are trying, obviously because the state rates are lower. And so sometimes it's a big lift for them, especially small businesses, to be utilizing the system for that. Sorry, I've got a gnat that's flying around here. But it depends on the area that you live in terms of what contracted providers and services can be provided. So the next question, are these programs only for Medicaid members, or can someone on Medicare apply? So the MAC and TSOA programs and FCSP programs, in particular, the TSOA and the FCSP programs, people can be on Medicare. For FCSP, care receivers can be under the age of 18 or at the age of 18 or older can be a care receiver and a caregiver. With MACA-TSOA, the care receiver has to be 55 or older. And some people 55 and older may not have applied for Medicare yet. Some people haven't taken advantage of that yet. So they do not have to be, if they're a Medicaid member and they're receiving categorically needy or the APB medical benefit or Apple Health, then they're considered a Medicaid member, then they would qualify to go under the MAC program. But in order to qualify for the MAC program, from a functional standpoint, there needs to be an unpaid caregiver with that. So for MAC, it has to be a dyad to go under the MAC program if they're already a Medicaid, receiving Medicaid benefits through medical for that. Okay. All right. So I hope that helps answer questions for that. I'm double checking the chat. So, when you're talking about the caregiver, if you're talking about caregivers, if you're talking about unpaid caregivers, there is no number or authorization. Even with the IPs, they don't have an authorization number either. They will have a provider one number is what they will have, but not to claim anything, just because that's how they get enrolled through the CDE system. The provider, which is CDE, we will do an authorization, and so CDE will receive an authorization number in order to be able to claim for that particular client for the services that they're receiving. But they don't receive an authorization number. We can provide this information. I believe Anthony should be able to get the I emailed him the PowerPoint, so he should be able to get that out to folks.
You did email that, and I did receive it, and that will be coming out this afternoon with all of the post webinar information that we normally send.
Okay. So I can understand that could be confusing when the AAAs or HCS, when AAAs are talking with the clients. In most instances, the clients usually are taken through the whole process, unless, often we rarely have anybody that receives any type of services on step one. And yeah, so the AAAs do have that conversation with them and saying, look, they're not going to receive this money directly. It's just that this is the limit of funding services and supports you can receive under these different steps. Most instances, they just walk through all of the processes with them, the NIFLOC, the PE, the screening, and the assessment, and just kind of take them through the whole point. The system will stop it, though, if they don't make it through the screening to move on to the assessment, because everything has to be locked along the way to go to the next part in the system. So we have had some people who did get stopped at step 2, and let them know, like, hey, you can receive these services. So it is an explanation. This isn't something that like that triangle, we don't really send that out to the public to see very often. We're just sharing it with you as professionals who work with the clients, just to give you an idea of what the benefit is. And it is a very small benefit for folks. Okay, so paid caregivers would receive a provider one ID. Okay, thank you for coming. Correct. The funds are used for respite and supplies as needed. And there we are able to, so the $844 a month they're receiving currently actually adds up to a 6-month budget, and they can utilize that 6-month budget how they want to. Let's say it's difficult to find a caregiver, but that client needs a wheelchair ramp, and that wheelchair ramp is $4,000. They can use their 6-month budget to pay for that wheelchair ramp. Now, if they do end up getting a care agency or someone to help provide that care, then what they would have to do, the case manager would have to do is do an exception to rule policy in order to get the extra benefits so that they can help kind of increase that 6-month budget to help support what those needs are. If it's a $7,000 wheelchair ramp, the case manager would do an exception to rule submission, and then we could get that. We go through our committee through headquarters to get that approval, to get that wheelchair ramp put in, or to get a home modification done. And of course, everything has to meet and follow all of our procedures and policies and CMS requirements to be able to do those, because the funding is through CMS. Okay, I'm bouncing back over to the Q&A. Great questions. If a client isn't on Medicaid but financially qualifies for this program, their unpaid caregiver can't become paid through CDWA. That is not correct. So this is where it gets complicated. Okay, so if you have a client who has an unpaid caregiver that comes through the door, and they're interested in receiving supports, they don't qualify for Medicaid because they're over income or they're over resources or they're not interested in state recovery, then they come through the door and that unpaid caregiver says, I would like to become a paid provider through CDWA. They can come through the door as a paid provider through CDWA. If they come through the door of the AAA, then that care receiver would actually be set up as an individual unless there's another unpaid caregiver, because to make a dyad, it has to be an unpaid caregiver with a care receiver. I know this is confusing, but if there's a third person that's like, I want to be that IP, then they can do that. But if there isn't, and that's that unpaid caregiver that comes to the door and says, I want to get paid, then it becomes an individual who gets enrolled. And then that unpaid caregiver can go through the process of becoming a paid caregiver. In the meantime, we can get some services set up for that care receiver while that unpaid caregiver goes through the individual provider process through CDWA to become a paid provider through that particular program. The benefits really don't change that much. It's just different language. So instead of it being called respite for what would be for the unpaid caregiver, once they become a paid provider, it would just become personal assistance services would be the difference. But they can still receive, whether they're an individual, the care receiver is in an individual, or the care receiver is part of a dyad, all of the services and supports are the same for both. So SSBCI, I do not know what that is. So based on educated guessing, I'm going to say no, because I don't know what the SSBCI is. These are the funds that we provide through the AAA for the McIntosh program. We have a contract with the AAAs to provide these program supports and services. And each AAA is contracted so much funding for them to support this program and the clients that they're serving. And then, like I said, everything goes through provider one. So that's that question there. And Anthony, you'll be able to get the Q&A and the chats and stuff to us so we can write a good response to
Oh,
me.
absolutely. Yes, I can definitely do that for you.
Okay.
And that SSBCI is the Special Supplemental Benefits for the Chronically Ill. That's what that acronym stands for. So I believe that's along the lines of Medicare, I believe, but I'm not quite sure.
Okay, so if that, yeah, so we don't do anything with Medicare. The only thing is making sure that they're utilizing their Medicare for certain services. For example, an example is a lift chair. So that is the motor portion of the lift chair is covered by Medicare typically if that person qualifies. So the person does need to go through the process of getting approval through Medicare or denied through Medicare for that lift chair. So if Medicare does approve the motor portion of the lift chair and they're enrolled in the clients enrolled in the TSOA program or MAC program, then that our program will pay for the furniture portion of the chair. If they're denied and it's indicated that there's a denial from Medicare to cover the motor portion, then the TSOA program will cover both the motor and the furniture portion of that. Another example, if a person is needing to have a motorized scooter, Medicare will cover up to like 80% of a motorized scooter. So whatever Medicare doesn't cover and that person's enrolled in TSOA, then the TSOA and MAC program will cover that added cost for that motorized scooter. Those are just some examples as far as that goes. So I understand there was some issues, but this is a really good video. I can play it for folks if folks were able to hear. Were folks able to hear the last couple of videos? Or no? I'm not seeing any thumbs up or anything. So I'll just bypass this, and I know we're running on time. So
Well, there are thumbs going up. People
oh,
can.
there's thumbs going up.
Yep,
Oh, okay, I
right,
didn't
yeah.
see that. Okay. I can run the video, and again, it'll be in the PowerPoint. So if you had issues with it, it's just a great wrap up to everything that we've talked about and why these programs are so beneficial for caregivers.
Because initially I couldn't figure out what in the world is wrong with Betty. It was very minimal progressive to begin with. It would seem sometimes a day and a half before she'd even get up out of bed. One of the things that I remember now that that we are talking about early signs, I remember how embarrassed I was by certain things that he had said, and this was like a year before his being diagnosed. Something really, really embarrassing to a friend that I just couldn't believe. Something very prejudicial. I don't even want to repeat it. And I remember telling Dad, Dad, you just don't say that. You just don't say that. And he was like, what? It's like, I don't understand. I was like talking to a wall. Like he couldn't figure out that there was anything wrong in what he had said. From that point on, I started paying more attention to signs, and I started seeing that he was getting confused with things that I was doing at home. One day, he put an entire metallic pot in the microwave.
She had thyroid cancer, and my sister was taking good care of her. Everything was working well. She started getting a little dementia, and my sister was dealing with it well, and then she had a stroke. So she couldn't do it. So she said, well, you have to take mom in. And I said, well, it's not a problem, you know. I'm blessed to do this, but it's all so overwhelming. I never thought I would, you know, need somebody from the outside to come in and give me a break.
What I see is a lot of caregivers that are very isolated in their homes. They've been taking care of somebody for often several years and pretty much felt like they could handle things. But as we know, after a couple years of providing care, particularly to somebody who has a memory problem, the demands on the caregiver grow continuously, and often they end up becoming ill because they're no longer paying attention to their own needs.
That constant care, you find little things start to irritate you. And you get a sense of, oh, I don't know how to put it. You've lost control of your own life. You're not making decisions anymore. Circumstances are making decisions for you. And you resent that.
That feeling, that perception, again, that my loved one is kind of taking advantage of me a little bit, doing too much, and there's a strain in that relationship, knowing too that there may have been a strain ahead of time. There's the objective burden, that feeling of you know, what happened to the rest of my life? I'm not having any fun. I don't have time with my wife. It's cutting into my job. It's just interfering.
Somewhere behind these doors, a family member, often alone, is taking care of a loved one with Alzheimer's or some other disability, or providing care for a loved one who is not ill, but only aging and no longer able to care for him or herself. In the field of caregiving, this is the home front, for the home is where most Americans will live out their last days. From all across Washington, caregivers, in their own words, want to share their stories so that you too can understand the long and often difficult days of the family caregiver, as well as the hope and help no further than one phone call away.
Well, if I had a friend who was in the same situation that we were in the beginning, I would say, let me make a phone call for you, and then I'll give you the number and see if you can't get some advice from Elderly Services, because they're wonderful. And I feel like I'm probably sane today because of they're inviting me to go to the support group. And, you know, when you're dealing with something that's really too heavy to deal with, you don't want to call in help. And that's kind of where you get, you're independent right up to a certain day, and then all of a sudden you're overloaded. And you think, oh, I can do this, I can manage this. And then you're it's way out of your element before you know it.
What happened was I was going to commit suicide. Because I'd had enough. And somehow or another got a hold of Bob Poindexter, Adult and Aging Care, and they stepped in.
Have you seen pictures of the Alzheimer's brain? The brain just kind of separates itself from its other parts and just shrivels up like a cabbage just dying without water. And you look at that in the picture and say, oh, no wonder that happened. And so I've gotten to the place now, I don't know, in the caregiving thing, I don't know, they're all those caregiving jobs are so bad. And it takes such a strong person. That's why we came up with this idea, because this young lady you'll meet a little later, I found out from her psychiatrist that she was thinking about suicide.
Because you see a lot of seniors and you see them struggling, and you see them struggling in the supermarkets or whatever, and they're having a hard time. Fortunately, in our case, I am a lot younger than Henry, so the maneuverability for me, but if we were both that age, where would we be? And if we wanted to stay in our home, where would we be without the help of aging and long-term care? I really think that needs to be it needs to be out there, whether it's the paper or the TV or an article in the magazine or somewhere. It needs to be there that people know of this service. It's been a godsend for me, a blessing, an absolute blessing.
If I know that somebody else is suffering somewhat with me, that makes my load a lot lighter, because at least now I can say, oh, wow, I'm not by myself. I'm not the only one going through this. And the lady that I'm talking about, she told me one day, she said, I've been doing this for 6 years. You know, you're the only person coming to my house in 6 years.
But getting back to Bob's organization, I feel that if it hadn't been for him and what he has done for me, I wouldn't be here today.
To see more videos or find help with your caregiving challenges, visit www.agingwashington.org.
So that is a pretty impactful video, and how basically it's, you can hear from Lisa and you can hear from myself, but these are actual caregivers in our state who have been able to benefit, and it's made a difference in their lives. So in addition, we have some resources available to be able to click on the different links for that. And we've been answering some other questions and stuff. So I'm just going to do a quick look through again. Okay, so we go out of that to the chat. Okay, so people are just wanting to, so I apologize for those of you who are at difficulty hearing with the sound. The links to those videos are in the PowerPoint, which Anthony's going to be sending out to you folks. So you'll be able to listen to those videos. They're available through YouTube on the web. So I don't see any other questions. So again, just email me direct if you're interested in receiving any type of outreach materials, and we'll get that stuff out to you guys for that. And then Anthony, if you could get me a copy of this webinar chat and the Q&A, because some people are putting their emails and addresses in there as well. So I want to make sure I get that information for that. So I just want to say thank you to everyone. Any last comments that you might have, Resa, to add?
No, just thank you for the opportunity to talk about our family caregiver programs. It really does make a difference to get the word out there and to get referrals to our program. And thank you for all the work that you guys do. So thanks.
Thank you. Thanks, Anthony, for having us.
Wow, thank you all both for being here and for just sharing. And this was very impactful, and for all the work that you do. Thank you very much for all that. And again, all of this information will be coming out to all of you guys in the network. And Adrienne, I'll make sure you get the copy of the chat with all the information. All right. But thank you both again. Everybody, have a great rest of your day, and we will see you for our next offering. Have a good day.